Hello, everybody. Good afternoon. Let's start this session on mental health and HIV with a sub-team supporting communities and turning stress into resilience. My name is Peter Smit. I'm an HIV and mental health activist and a representative of the Dutch HIV Association, and as such, I'm also a community representative at the Dutch HIV Monitoring Foundation in the HIV Advisory Board. We are going to talk on mental health and HIV. These are my disclosures. This symposium is in fact organized by the IAS itself. When Alexander Pastoors from the conference committee came with the idea, we put it forward to Peter Rice and Linda Becker, and of course they took it forward and gave us the leeway directly to Robert Remian, and Robert wanted to come, and then all the other people came as well. So we are very honored to have them here on your and our behalf. Now, it's a symposium session, and symposium sessions are organized for critical issues that defy simple solutions. And in this case, we're going to speak about mental health. The speakers are all invited, and we're hopefully engaging with you, the delegates, toward future ways forward in mental health and mental health issues. Why mental health and HIV? Well, mental health is an important cause of mortality worldwide and also in the HIV-infected population. It's, I think, next to TB, the biggest cause of mortality per se with HIV. Mental health issues are important syndemic factors. Well, syndemics are interacting epidemics. It's been the topic of discussion in many sessions here as well. And those interacting epidemics could be, of course, heart and vascular disease, co-infections, but indeed also depression, anxiety, feelings of isolation, alcohol and substance dependency. This is an overview of the session. We have 6 speakers. They all are getting 10 minutes each to speak. And then hopefully we'll have 20 minutes for questions and answers involving with you and with our panel. Having said that, I'd like to give the pulpit to my co-chair, Robert Remian, who is from New York. He is a professor in psychology and has been working in the HIV field in pro bono work, activism, research, and what have you, since the early 1980s. Robert Remian.
Thank you, Peter, and good afternoon, everyone. Oh, these are yours. Okay. Okay. Pleasure to be here with you all, and we look forward to a lively discussion after we all get to speak. I have no conflicts to report. As Peter just said, why we focus on mental health in the context of HIV prevention and care. We all know that there are significant gaps along the HIV prevention care continuum. Mental health problems and disorders influence every step of the cascade. People at risk for and those living with HIV have significantly higher rates of mental health problems, symptoms, and disorders. I believe that if we do not address mental health, we're unlikely to ever achieve 90-90-90 or go beyond to end the HIV epidemic. And of course, I think it's always important to state that there's a human right to health, meaning that everyone has the right to the highest attainable standard of physical as well as mental health. Here you see the global burden of mental, neurological, and substance use disorders as measured by disability-adjusted life years or DALYs by age. These contribute to a shorter lifespan. And I'd like to point out the age here and the similarities in the age burden relative to the age burden of HIV, with a rapid rise in late adolescence, peaking in young adulthood. And among adolescents and young adults living with HIV, more than 60% have some type of mental health disorder. Let's talk for a minute about mental health and HIV prevention. Mental illness is a risk factor for HIV acquisition. It contributes to 4 to 10 times the increased risk for acquiring HIV. And when there are comorbidities, and Peter already mentioned syndemics, when we have things like mood disorders associated with alcohol and substance use problems and other conditions, there's an even higher risk. Peter mentioned syndemics. It's a set of linked health problems involving two or more afflictions interacting synergistically, contributing to excess burden of disease in the population. And our research in syndemics focuses on communities experiencing co-occurring epidemics that additively increase negative health consequences. Here's just an example of research, a syndemic example, looking at these co-occurring conditions among over 4,000 men who have sex with men across 6 cities in the United States, looking at depressive symptoms, alcohol use, stimulant use, polydrug use, and the experience of childhood sexual abuse. And what you see in this graph is that probability of staying HIV negative goes down as the number of these conditions increases. Just to talk for a minute about what we're seeing in some of the implementation of PrEP in these PrEP studies, that higher depression scores are associated with lower PrEP drug detection or adherence, as well as condomless receptive anal intercourse. So it may be that depression screening and treatment may be part of the key to maximizing, ultimately, PrEP efficacy. Moving on to people living with HIV/AIDS. This is based on a series of wide range of studies in the United States, again, where we're comparing the presence of these selected mental health disorders, specifically alcohol use disorders, other substance use disorders, depression, and lifetime PTSD. And you can see the significant difference of those among people living with HIV as compared to the general population. This phenomenon is really true across the globe. And for example, in South Africa, we see 26 to 38% of people living with HIV having some kind of mental health problem compared to 23, having trouble seeing it up here. Versus 13% in the general population. And again, just to mention that these are even higher in young adults, young adolescents and young adults. So why the high burden of mental health and HIV? I think everyone in this room probably is acutely aware of the populations that we work with, that we treat, that we are in our studies, dealing with these comorbid conditions. And all of these boxes, all of these things can influence health outcomes. Whether it be demographic factors or environmental factors, psychosocial, biological factors, community factors. I'd like to point out that in these boxes, some of these things can contribute to poorer health outcomes, but there's also some things in here that contribute to resilience, which is part of what we're talking about today. So a question of whether you have positive social support versus negative social support, or if you have safety and cohesion in your community versus a disorder or violence in your community. And very importantly, pointing to the intersecting stigmas that our populations are coping with. And this has been thematic at this conference. The stigma of mental illness, the stigma of HIV, the stigma for many for being a gender and sexual minority, someone who uses substances, someone who engages in sex work, or for many of our populations being of racial ethnic minority status in their community, their country. I'd like to talk for a minute about the increased risk of mortality associated with depression. These studies all happen to be with women, but you're seeing here that there's, in some cases, twice as women with chronic depressive symptoms being twice as likely to die than women with no depressive symptoms, even when adjusting for other predictors of mortality. And in the third bullet, you'll see that women with chronic depressive symptoms was associated 3 times the hazard of mortality amongst women on ART, and 7 times the hazard of mortality with women not on ART, in both cases compared to women on ART with no depression. And more recent data is showing us a dose-response relationship between depression and length and HIV outcomes. With each 25% increase in days with depression, we see a 19% increase in risk of mortality. I'd like to just but take a minute to talk about the potential biological mechanisms that are operating here. We know that there are direct effects of depression on the immune system with chronic immune activation and HPA dysregulation, as well as HIV contributing to inflammatory proteins. We know HIV crosses the blood-brain barrier, thus this activation is in the brain as well as the central nervous system. and the reality that this chronic inflammatory response to HIV infection can produce an elevation in cytokines leading to a cascade that increases neurotoxicities that are specifically associated with depression, suicide, and anxiety. So we have that side of the coin. And then, of course, many of us are keenly aware of the behavioral pathway of the association with mental health impairment, contributing to increased risk behaviors, to lower rates of HIV testing and linkage to care, retention in care, accessing ART or initiating ART, and staying on ART. All of these can lead to non-optimal HIV treatment and thus poor health outcomes for self, and then of course with our U equals U about in terms of the other sex partners in the community. So I would just say whatever the pathway, it's clear that we need to address mental health problems if we want to improve health outcomes along both the HIV prevention and treatment care continuum. And there's a growing body of evidence that we're seeing the benefits of integrating mental health screening and treatment into HIV care, starting with the first critical step of screening and providing treatment, mental health treatment, integrating it into care, addressing mood disorders, substance use disorders, all of these things. If we address these things, we're seeing evidence of reduced sexual risk behaviors, improved adherence and retention in care, all of this leading to reduced viral load, which of course is key for the health of the individual, and as we know, for reduction in HIV transmission. But of course, the reality we are facing is there are significant mental health treatment gaps across the globe. The majority of people with mental health problems across all country settings do not receive care. And there's many contributing factors to this, and unfortunately, a powerful one is the stigma of mental illness existing at all levels. I hope in our discussion, and we'll hear some examples of some evidence of interventions, we can talk about this challenge of short-term versus long-term. There's an increased focus, and there's often a demand for brief interventions. There's some evidence for success with certain brief interventions. Some can be manualized, administered by a wide range of staff. However, there's also evidence that longer and multi-level interventions generally have greater and longer-lasting benefits. I would say the bottom line is level of intervention needs to vary depending on the severity of the problem and level of need for the particular patient. So given this resource reality, how do we cope with with the desire to scale up mental health services in the context of rapid scale-up of ART distribution? Outcomes will look different in different regions, and we're going to hear some examples from the panel. But let's be mindful that there's a spectrum of mental health impairment and level of need. Most people actually only need minimal intervention or don't need any specific mental health intervention. There's a lot of resilience in our communities, but some need greater intensity of interventions, and we have to challenge ourselves what resources are we willing to put into those with greater need. And I would say we need more evidence-based stepped interventions with algorithms and tools for determining level of need. And most importantly, I think the cultural sensitivity of our care settings and how we deliver services. Those of you who saw David Mellebranche this morning at the plenary really drove home the point, and I always like to drive home this point. I think this is so key, not just for HIV care and the kind of service we provide, but certainly for mental health care. The cultural sensitivity of delivering it to our diverse populations is really key to, I would say, key to success. So the importance of diversity and tailoring our interventions for young people, for women, for men, and dealing with the different problems that people face depending on where they're coming from and what kind of problems they're facing. So in wrapping up, I'd like to end on a note of resilience. I think the U equals U campaign, which is very powerful, it's got all the science and evidence behind it, so I hope we all support it. It grew from the community, and I think it has the potential to, and there's the hope that it can reduce stigma. But I think there's evidence, and if you read these quotes, I don't have time to read them, but you can glance at the bolded parts. I think it leads to reducing some depressive symptoms and isolation for people. It can increase well-being and outcomes, and I just think we all need to get behind it in lots of important ways. Thank you for your attention.
Thank you, Robert. Our second speaker is Dr. Mellons. She's going to speak on strengthening resilience among adolescents and families. She is Dr. Mellons is a clinical psychologist and professor of medical biology at Columbia University as well. And she has been working in HIV since 1990. And she's also co-founder of a special needs clinic at the New York Presbyterian Hospital, and it's one of the first and largest mental health clinics for children, adolescents, and families affected by HIV, poverty, and substance use. Claude.
Thank you, Peter. It is a pleasure to be here today to talk about a population that when I started working with them in the early 90s, there were very few options for their survival. And now, as we've been hearing, there are really millions who are reaching adolescence and beyond. Unfortunately, we also know adolescents are a very high-risk group for non-adherence and poor health and mental health outcomes, and so very deserving of our attention. We also know, as we've just heard from Dr. Remian, that we have great medicines for promoting health, but we also know that the strongest barriers to promoting health and overall well-being are behavioral, psychosocial, or contextual. And this is particularly true for adolescents and young adults, where some of the issues are compounded by the fact that they're growing up in families where multiple people may be living with HIV affected by the same medical, economic, social, and contextual stressors that we heard and saw in that model from Dr. Remian. So to give you just a very brief sense of that risk, in a study of perinatally infected young adults who I've been following since they were in adolescence in New York, the majority are actually showing resilience. They are meeting educational or work milestones and other adult transition milestones, yet 50% are not virally suppressed, over 40% are living with a psychiatric and/or substance use disorder, and like many of their peers, a high percentage are engaged in condomless sex. Unfortunately, we know there are very few evidence-based interventions for this population, particularly in low and middle income countries. That's true for adolescents in general, and it is for sure true about adolescents who've grown up with HIV. But we also know that prevention of health-impairing behaviors before they begin is much more effective than intervening after behaviors are established. So waiting until they reach young adults is just too long. And so I think it really behooves us to think about reaching people at much younger ages. So I'm going to talk very quickly about two models of evidence-based care I've been fortunate enough to be involved with that are in Africa and Asia. CHAMP Plus and SUBI Plus are two psychosocial programs that are integrated into medical care settings. They target multiple behavioral health outcomes, mental health, sexual risk, and adherence among early adolescents living with HIV before risk behaviors emerge. They also target multiple systems to support those young people, the youth, their family, and maybe the clinic or their community. Both are based on evidence-based interventions for uninfected youth. We don't always have to reinvent the wheel, but I'll come back to that. And really importantly, and I think Dr. Remian touched upon this, investigators for both these programs worked very closely with local community stakeholders in development, implementation, and evaluation. And those stakeholders included youth themselves, their providers, and their caregivers. And we know that community collaborative work is critical for ensuring feasibility, acceptability, and sense of ownership of an intervention, which we need for scale-up. So I'm going to start by talking about CHAMP Plus. It's based on the Collaborative HIV/AIDS Mental Health and Prevention Project, or CHAMP, developed by my colleague, Mary McKay. CHAMP is an evidence-based, family-based intervention supported in multiple NIH-funded clinical trials in the US, South Africa, and Trinidad. It was created by researchers working with clinicians and families for HIV uninfected inner-city youth and their families. Its aim is to prevent health risk behaviors and promote mental health of young adolescents living in vulnerable communities. The way CHAMP works is that multiple families come together, about 8 to 10 at a time, in their communities for 10 sessions. They share a meal and they participate in separate and combined youth and caregiver groups focused on a semi-structured curriculum. That curriculum has multiple goals. First, to strengthen the adult protective shield around young people. So strengthening parent-child communication, family decision-making skills, helping parents take leadership in aspects of family life that offer youth protection, such as supervision and monitoring, but then also increasing youth self-esteem, social problem-solving skills, coping, and peer negotiation skills in situations of sexual or substance use risk. It also aims to increase HIV knowledge, particularly around prevention activities, and then importantly, to increase social support within and between families who are often isolated and need each other to support each other in protecting young people. Because it was developed for lay staff administration, it's ideal for resource-limited settings. So meeting with stakeholders in South Africa to begin with, the stakeholders there really wanted to retain much of what CHAMP was about. So lay counselors administer this intervention, but they administer it in clinics, which is a safe space for young people with HIV to be. Multiple family groups come together, and they retained much of the 10-session curriculum. What's in black here is what was in the original CHAMP. What's in red is what we needed to add to address their needs in terms of HIV, surviving loss and bereavement, adherence to medication, identity and acceptance of one's status, but also just as a young person, disclosure and stigma. So we have completed several pilot randomized controlled trials in South Africa and Thailand, funded by NIH and several other funders that I'm going to just show you briefly a little bit about. The curriculum in Africa and now Asia is delivered via a cartoon-based structure. So this was considered really important to families to communicate about difficult to discuss topics or sensitive topics, such as sex or illness or HIV or death. And so this has been also, it allows discussion in places where there may not be literacy. So families can follow the cartoon actions as they go along. So I'm just going to show you a few snippets. This is the VUCA family that was chosen by the stakeholders in South Africa. VUCA means let's wake up. 12-year-old Temba has just lost his parents to AIDS. He has gone to live with his aunt and uncle. He is feeling very sad. He's lost everything that he knows. He's sleeping on a couch. He's clutching a memory box. And so families talk about how Temba feels, and then they problem solve about what Temba's family could do, and then they talk about their own lives and how this applies to themselves. Temba's aunt realizes that maybe he has HIV, and so he's tested, and he does, and here a nurse is talking to him about the need for lifelong adherence. Again, families talk about their own experiences with that. Like many young people his age, Temba likes somebody, and so here he's talking to his best friend about whether or not he should tell a girl that he likes that he has HIV. I'm just showing you a couple of pictures from Asia. In Asia, the stakeholders there, the families changed the title. It translates into walking together. They also changed the storyline to reflect what they thought was more of their epidemic. This is 12-year-old Tem. He's living with his mother, who's also living with HIV. He's lost his father to AIDS. They are living with their grandmother, and she has a new boyfriend who initially doesn't know their diagnosis. I'm just showing you one clip from Asia where you can see how the storylines differ a little bit. Tem is feeling sad that he lost his father. His mother acknowledges that's an important feeling, but instead of belaboring it, she tells them they need to keep a stiff upper lip, and their father wouldn't want them to be sad. It's much more difficult in the Asian context for these young people to really talk about the sense of loss and bereavement, but the cartoon helps families do that. We have finished the 2 trials in multiple pediatric clinics in each setting, and at both sites, over 95% attended almost all the sessions. And intervention participants improved in most areas compared to standard of care, had greater improvement in self-reported adherence, HIV knowledge, caregiver-child communication, perceived stigma, and in Thailand, improved mental health. So that's the family model. I'm going to give you one more model, which is Subi Plus, developed by my colleague Fred Sewamala in Uganda, funded by NIH. It takes on multiple systems, as does CHAMP, to promote adolescent development, resilience, and well-being, but it does this by acknowledging the devastating role of poverty on youth and adult transition. It was originally designed for uninfected orphans and vulnerable children, also to address mental health and reduce risk behavior. But it does it by improving the capacity for economic stability of the child, their family, and their community, working with local banks and families to teach youth about savings and loans and vocational skills. So for each dollar that the youth saves, they're allowed to open up a bank account and they put in the bank, the grant matches it by $1. That money can only be used for education or vocation. And for kids who stay in school, the grant also provides their uniforms and books and supports them in those activities, and they are also taught some vocational skills. And the hope is also that their caregivers and family members start opening up bank accounts as well and are learning from this process. SUBI for uninfected youth has had significant impact on thousands of youth in terms of mental health, and sexual risk. Dr. Sawamala and myself and Mary McKay then adapted it for youth growing up with perinatal HIV infection with the goal of adding art treatment adherence to the list of targeted behaviors. So SUBI is given as well as Champ Plus informed cartoons. These are very impoverished clinics, and so we wanted to have both groups receive some infrastructure there. We just completed a 2-arm randomized controlled trial, 39 clinics in Uganda. The first paper is out. The proportion of virally suppressed participants in the intervention condition increased tenfold compared to the control group by 24 months post-baseline. So we were really happy about these results, and the hope is that will then affect mental health and resilience for these young people. So to conclude, both of these programs, Champ Plus and SUBI Plus, adapted for early adolescents living with HIV in 2 African and 1 Asian contexts show promise. Both show that interventions from one context or population can be adapted for others, given that some needs are universal. Adolescence is a challenging time, but a key opportunity for prevention. And supporting families and communities can be a critical tool in that effort. However, delivery needs to be culturally and contextually tailored, and stakeholders from affected communities need to be involved in the development and delivery to promote ownership and sustainability. To end, I just want to give this quote from UNICEF in 2011. Adolescence is an age of opportunity for children and a pivotal time for us to build on their development, help them navigate risks, and set them on the path to fulfilling their potential. Thank you. I just want to thank everybody on this page that I'm leaving with you. I am the voice today, but it really does take a village of collaborators. I want to thank NIH for funding this work and the youth and families who gave us their time.
Thank you. The next speaker is Dr. Jacqueline Hoare from South Africa. She is she is a neuropsychiatrist and associate professor at the University of Cape Town, and is liaised as a senior consultant psychiatrist at 2 hospitals in Cape Town. She's been working in HIV since 2004, and she will also be speaking on adolescents and families in sustainable community-based mental health programs in sub-Saharan Africa.
Hi, thank you. I'm very grateful to be a part of this mental health symposium, and I'll be talking about mental health among adolescents living with HIV in South Africa and addressing isolation. So somewhere between the ages of 10 and 11 years old, at the start of adolescence, a young person's sense of self transitions from concrete terms like I have a dog named Jake and I'm good at sports to more complex description like abstract personality characteristics. So I'm complicated, I'm sensitive, I'm outgoing, I may be self-conscious. So this journey is necessary, it is unavoidable, and it can be wonderful and exciting. However, it can also be very painful if a young person is having to integrate a chronic stigmatizing illness into their sense of self and develop a sense of how much this illness defines who and what they are. And negative self-perceptions like I'm different or I'm unacceptable will certainly increase the risk of mental illness in young people. In addition to this, feelings of otherness can lead to withdrawal, isolation, and loneliness, again, increasing the risk of mental illness. So the outline of my talk is I'm going to be sharing with you our baseline mental health data in our longitudinal cohort study called CTAC in Cape Town, and then also share with you some pilot data that we have on the social networks or social complications of HIV infection in adolescents. And then finally to share with you our peer support intervention at Kudex Hospital in Cape Town to try and address isolation and social complications of HIV infection. So I'm going to whiz through this quite quickly, but in our HIV-infected adolescents in our CTAC cohort, we find a number of mental health symptoms or issues. Firstly is that our adolescents were functioning poorly compared to their peers. In addition to that, they were more likely to have poor self-image, higher depressive symptoms, more likely to have issues with motivation or the neuropsychiatric syndrome of apathy, and more likely to have symptoms of ADHD. I certainly do have a sense of working with these young people at Kudex Hospital and in my clinic that social networks are affected negatively by any chronic illness in adolescence. However, I do feel that this is more of an issue for adolescents living with HIV. Most of the young people that I care for in my clinic, when I inquire about the quality of their relationships with their closest friends, are not even disclosing their status to their best friend. I certainly can't imagine what my adolescence would have been like without being able to share such a significant portion of my life with my friend. Developmental theory suggests that adolescents are particularly sensitive to and motivated by their social networks. Social networks are thought to influence behaviors like ART adherence by providing opportunities for social influence, social comparison, social support, and social engagement. Empirical research has demonstrated the importance of social networks to various aspects of adolescent health. Yet we know very little about the structure of HIV-infected adolescent social networks and the ways in which these networks may shape HIV care, mental health, and engagement behaviors. So we used a customized network data capture instrument based on an existing tool called Network Canvas to enumerate the egocentric social networks of participants enrolled in CTAC. This tool has many benefits, including an interactive touchscreen interface and a user-centered design. So our adolescents were given a tablet with a blank canvas, and they were asked to visualize themselves as being at the center of this canvas. The next step was the name-generating phase, where they were able to add dots, and each dot represented a person in their network. And they were asked to place the dots according to closeness. So, for example, if a dot is near the periphery of the circle, then this person was not particularly close to you, in your network, but not particularly close. Once they achieved that, we did a name interpreting phase where we asked adolescents to give additional information about each of these dots. So are they mum, are they dad, are they somebody at school, somebody at the hospital? And then we also asked them to group them together according to sub-networks. So for example, everybody at school would be in a little network, everybody at home would be in a little network. In addition to that, they could also draw lines between the individuals who spend time together. So once this phase was over, we had a network canvas for each individual adolescent. And not only were we able to then assess the richness of their social networks, but also the quality of the relationships between the individuals by asking additional questions. So, for example, we could ask who in the network knows about your HIV status, and the adolescent could depict this by using colors. So color would be from blue to red, so hot and cold. Red would represent higher levels of, for example, communication, levels of trust. We could also use lighter or darker colors, where the darker color would be yes to disclosure or perceived support. So I'd like to thank Marta Mulawa from Duke University, who joined our CTAC team, for her permission to use the social network data and for the very striking visuals that she created. Marta also collected some social network data from HIV-infected adult women The adolescents from CTAC are on the left-hand side, and the HIV-infected woman on the right. And as you can see from these striking visuals that Marta created, was that the richness and complexity of social networks in HIV-infected adolescents were very poor compared to HIV-infected women. We then asked these HIV-infected adolescents from CTAC a number of questions. So the question on the top was frequency of communication. So how often do you communicate with people in your social network? And again, you can see from the lighter colors that adolescents were less likely to communicate with people in their social network than HIV-infected women. There were also lower levels of trust in their social network, as depicted in the bottom. The other questions were asked about HIV status disclosure. And as you can see from the top of the slide, that adolescents were less likely to disclose their HIV status to people within their network than HIV-infected older women. The next was emotional support and medical support, and here we see very similar patterns. That adolescents are less likely to receive the emotional support and medical support that they feel that they need. So we have attempted to address these social complications of adolescent chronic illness at Groote Schuur Hospital. So we initiated a group in August 2017, which was initially funded by a Groote Schuur Hospital Innovation Award, but since January 2018 has been funded by the One-to-One Children's Trust. So we, as a group of clinicians caring for adolescents in a very adult environment. Groote Schuur Hospital is primarily set up for adults, so there are issues with transition and care. And we were wondering whether we as clinicians were adding to the stigma by treating adolescents with HIV in separate clinics, in separate wards, in attempt to protect them from accidental disclosure. So our innovation was to integrate adolescents living with HIV with adolescents living with other chronic illness in a weekly group. This is our group poster, which can now be found all over Groote Schuur Hospital because we feel that we're better together. So the Adolescent Clinician Group provides a weekly, open, facilitated, structured group available to any adolescent requiring chronic care from Groote Schuur Hospital. The regularity of the group, which is held same time, same place every week, has become a safe space for adolescents to access care when they need extra support, if they're feeling alone, needing to socialize with peers. The interdisciplinary adolescent group is something I'm enormously proud of. We're a group of people primarily caring for adults in a very adult context, but it's very diverse. We have dietitians, occupational therapists, physiotherapists, psychologists, psychiatrists, obstetricians, gynecologists, pediatricians, and infectious diseases specialists who are all donating their time to this group. And the topics that we address not only relate to caring for a chronic illness, but also importantly deal with general health, development, and mental health issues. Adolescents with chronic conditions not only have illness or disability, but they also have the same needs, physical and psychosocial burdens as their peers. So several studies have addressed this issue and have shown that these needs are not adequately met or may even be ignored because illness is focused on with adolescents, which is of course what they rebel against. So we've attempted to address diverse topics which include sexual health, contraception, vocational choices, diet, self-esteem, body image, and conflict resolution. In the first 6 months that we had the group, we also identified 9 young people who showed good leadership qualities, who seemed very committed and were open with their other group members to be peer mentors. So they underwent some counseling training in our summer holiday, which is in December. And it is with these peer mentors that adolescents have exchanged a lot of ideas and feelings, and these encounters have contributed to identity formation, which I will share with you at the end of the talk. So this group of peer mentors acts as a bridge between the patients and the medical team. They have administrative roles in running the groups, and in addition to the Thursday group, they also support adolescents in the clinics where they receive their medical or surgical care. So this may be in a transplant clinic, a renal dialysis clinic, an endocrine clinic, or an infectious diseases clinic. And as they've become more confident or skilled, they have also run their own independent groups. So we've had some feedback from the group members. The first question that we asked them was, how Has the group improved your mental health? I'm more open now. I can count on them. Some of them have become my role models. My self-esteem is higher. I'm happier. I've learned so many things about different patients, and yet we are still the same because we all suffer from illness. I'm more confident. I'm more determined with life. It's helping because I'm hearing and seeing different things all the time. Has the group improved your social network? Yes, big time. Yes, and I'm more open with them. We're communicating with each other over the phone, and we're giving each other motivation and keep looking forward to life. I've gained more friends at the hospital. Meeting different patients is nice. I found it easier to speak to people. I get to chat with people, many people helping each other with situations and life problems. Has the group helped with feelings of loneliness and isolation? Yep, it helped because we interact with each other not only on Thursdays, but in our everyday lives. I'm more aware that I'm not the only one that is sick. It has taught me that I can't isolate myself. I don't feel like I have to hold back, totally. I have many, many people to thank. Our funders, our co-authors, Kudex Hospital, the One-to-One Children's Trust, Rebecca Sherby, Anka Davidson, Marta Mulawa, and of course, all my wonderful teenagers. Thank you.
Thank you, Jacqueline. The next speaker is Paolo Gorgoni. Paolo is a born Italian. He's of Italian descent, but currently living in Portugal. He is living with HIV, and he is giving a personal perspective from the community's view on HIV and mental health. He is also been active in the field of HIV since 2012, and since 2013 he is a board of director members of PLUS, which is the LGBT network of people living with HIV in Italy, and is also a member of an advisory committee of the project Lisboa Fast Track Cities Initiative. And he embodies his activism in his research of performing arts under the stage name of Paula Lovely.
Hello, everybody, and I'm very grateful for being here today. Let me just know this is the other. Sorry, how do I get back? Okay, this presentation is probably going to look a little bit different from the others you've listened to so far, as it's meant to be a way of showing how a personal perspective can be given on how to handle mental health while living with HIV as an activist and as a performer. And the reason why I decided to give a speech and create a presentation about it is because, as it's been noted even in the previous presentations, in many communities, even when there are no conditions for having a good mental health, it has been noted that there is some resilience and there are some ways to kind of cope with the mechanisms of mental health while living with HIV and facing stigma. And I wanted to disclose which of these coping mechanisms have been mine. As a background information, I was diagnosed that I was relatively young. I was 23 years old and I was living far from my family but still in my home country. I was young, scared and uninformed, and I had got out of an abusive relationship that all created a perfect setting for having some troubles with my mental health, even without an HIV diagnosis. But of course, the HIV diagnosis also created some further conditions for my mental health to degenerate, and including a very big change in my life plans, because I was about to leave for living in Brazil, and I've never left, I've never done that experience. And so I had to reshape my life, and I've started experience typical mental health symptoms, such as fatigue, anxiety, and a very big sense of loneliness, sudden mood changes. And I've started developing a fetish for the death at a young age, as you can see from the picture of this many artists who were dead at 27. Although I had soon to acknowledge that a better life expectancy was waiting for me outside, because in the meanwhile, all the imagery we had in the 90s and in the early 2000s about HIV was being reshaped by treatment. And in Western European countries, at least, it was relatively easy to access treatment and to know that you would have a healthy and long life. So the main challenges were more in the social part of my journey through living with HIV. And one of those was trying to reshape my identity as intersectional. I was not only being a gay man, but a gay man living with HIV. And this led me to have a lot of doubts about my future. And this is incredibly common in the communities I've been working with and in the counseling I've been doing on the phone and in person. At the moment of the first diagnosis of HIV, the diagnosis of HIV, many people are facing this kind of fears. And this leads, of course, to some mental health issues, or may lead to some mental health issues, whereas many national healthcare systems behave as mental health was a luxury good that you can only have if you can afford it, because accessing for free to mental health in the long term can be extremely difficult in some contexts, even within European Union, not only in countries we don't know much about, or they're very far from us, or they have very much more difficult conditions in terms of how the national healthcare system is built, but even where we know how it works and close to us, and in a country which is similar to our home country, even navigating the system with some knowledge, sometimes it's very difficult to access mental health services. And what was left to me to do was to decide what to do with the pain. And fortunately, as in many other cases, communities have been united around and against HIV. And within the communities, I've started doing activism. And it has helped me a lot as a coping mechanism, because it would help me work with information, support empowerment, and to understand that visibility was also one of the main points of communities in order for their voices to be heard. And so this is how I reacted to some death threats I received online because I'm an activist in 2016, and my reaction was, okay, I go to the Pride and I will wear a t-shirt disclosing my HIV status so that not to show any fear because of this. And I've started becoming engaged even within the social networks, because we've seen how important they can be in fostering social relationships, but also as a background where people can easily access information. And there is a lot of stigma and prejudice in the social networks as well. And as gay men, many of us know what we face when we say we're HIV positive in a dating app. But then I was not happy enough for just being, a battle fighter in the social networks and a peer supporter in the community through associations I worked with. And I was developing an artistic discourse that had not connections with my HIV activism at the very beginning. But then arrived one day in which I was offered the main stage in a pride parade in a European capital where I was living, that is Lisbon, and in a country where apparently no other people under 30 years old or under 35 years old have ever disclosed publicly before I did. And so I was supposed to just go on stage and sing as I did today. That's why I still have my makeup. But then I was like, okay, I'm having this big stage. I feel I identify as a community representative, and the fact that I'm using my drug persona does not take any of this off. So I have a social responsibility towards these communities where this silence is still so strong around living with HIV and around living with HIV and having mental health issues. And so I decided to just come out on stage in a short speech, and this led to creating a reflection on this process. And so I decided to better understand why I decided to do this and how it improved my activism and my capacity to reach communities and to be inspiring or helpful to someone else out there. And it went through 4 main sections, I would say. I mean, I had a a code need related to the language. I mean, political language, many times, and so very often, and even scientific data is easy to deliver and is easy to be understood in a context like this where everybody else is working in the field. But what happens when we try to reach other people who might not be interested in joining an HIV conference but still at risk of getting infected with HIV or of getting isolated because they've got HIV? So artistic language would let me decipher this political discourse to live and explain advocacy through the stories that make advocacy itself necessary. And so the attempt is to give the best of my voice. On the other side, there was this, I assume, the personal need of artistic creation, because artistic creation requires a research around the topics that could give a better perspective and a different perspective on daily life. And a work that embodies the activist, the author, and the drug persona fulfills the need and to address orientation, gender, social perceptions of non-conforming identities, and the issue of social responsibility, as I said before, and reaching a different audience. So I think in my personal journey and in the personal journey of people I've met and I've worked closely with, performing arts and activism together kind of fill the void left sometimes by other forms of activism, and it provides a representation that goes through media that we lack a lot as people living with HIV, as this lack of representation fosters our sense of loneliness. We feel like we're the only ones who had a diagnosis or who are facing these problems or who are passing through mental health issues. It gives visibility to people living with HIV and helps in changing the societal patterns and expectations around people living with HIV and their lifestyle, and generally speaking, reshape the imagery around HIV. So what are the desires of a drug activist in this particular moment of their life? Eradicate stigma related to mental health itself first, because as I said, it's often overlooked and treated as a luxury good. React to the shame associated with living with HIV. Improve the awareness about mental health with a special attention for those who living with HIV, because they might have a specificity that needs to be addressed. And to be open to mental health and dispel false myths about it, be inspired, and then hopefully inspire. These are my acknowledgements. I'm not going to read them all. I thank you all for listening to me, and if you have any questions at all, please feel free to address them with me. Thank you.
Thank you, Dirk. Our last speaker for this session will be Dr. Henry Kudex from Germany. She will speak about HIV and substance use, individual and social aspects of mental health care utilization. Henry Kudex has been working in the area of HIV, mental health and substance use disorders with a focus on MSM since 2008. She's a psychologist and trained psychotherapist, and she is attached to the University of Duisburg-Essen, particularly at the Department of Psychiatry and Psychotherapy in Essen itself. Henry Kudex.
Yeah. Thank you for inviting me. First, my disclosures. And due to a short time, I will focus my presentation on the group of MSM. And as a kind of disclaimer before, I want to point out that substance use in the context of sex is not a problem per se. In my presentation, I will talk about those who lost control and identify their use as problematic and seek for help and support. Let's have a look at the prevalence for substance use in MSM. There's a higher prevalence in MSM compared to heterosexual men, and a higher prevalence of substance use in some populations of HIV-positive MSM. And marginalized subgroups like low socioeconomic status or low educational levels or sexual minorities are more affected. Regarding the prevalences, we have to keep in mind that some limitations regarding the methods, like sample bias and data are often collected in clinical settings. They are rarely populational based, and which might contribute to a biased picture of substance use in MSM. And we know a lot of MSM in urban regions and high-income countries, but about the rest. I want to talk about the chemsex phenomenon, the sexualized drug use and substance use immediately before or during sex. And typical substances are crystal methamphetamine, GHB, GBL, ketamine, methadone, and others. And chemsex seems to be associated with cannibal sex and some other factors which may affect sexual health. And the findings are inconsistent about the influence of chemsex on mental well-being and health. Some studies find heightened rate for depression or anxiety in populations who do chemsex, and others did not. What are motives for chemsex? Byrne and his colleagues found 4 motives in their review on the literature. Central motives listed in no particular order. First are hedonistic motives, sense of belonging to gay community, coping with problems, managed distress, negative emotions or thoughts. Of course, motives can change over time and by an individual person, or one can be more or less relevant in the course of time. What is access and barriers to support service? My personal professional background is addiction therapy and research, and from this perspective, I can clearly say that the addiction service is not well prepared for chemsex users. If I talk about with my colleagues about chemsex, first they turn red and then they ask, "What are you talking about?" And then, as well, there's a lack of knowledge in the standard addiction service about cultural aspects of the LGBTIQ community, and as well a lack of expertise in the area of sexual health. About the chemsex users' perspective, studies and practice show that there's often fear of being not understood or accepted by the clinicians in the addiction services, fear of being stigmatized, unawareness of existing services, and limited knowledge of harm reduction services like needle sharing or needle sharing exchanging, limited knowledge that there are established programs in this area, and often no self-identification as an addict, and so therefore they don't need see the why it might be useful to go to the addiction service. This leads to 3 major challenges. First, regarding settings, regarding mindset, and regarding networking. First, opportunities for setting where help might be located. First, sexual health clinics versus specialized chemsex service in the established addiction services. We heard a lot about PrEP. PrEP settings can be a chance to address substance use, and but also we heard a lot about adolescents and younger adults. Online counseling and e-mental health might be useful, especially for those who live in the more rural areas. And of course, peer support. Peer support has a long tradition in both areas, HIV and addiction. In Germany, peer support for addiction is very successful and has a very long tradition. And some opportunities regarding the mindsets for clinicians and researchers. We have to consider the individual consumer motives from the people and promote a change in paradigms in our thinking from a public health perspective to individual care perspective, and fight stigma. Of course, there are stigma as well in the mental health area, HIV, and in the addiction as well. And last opportunity, networking, create awareness for chemsex users' needs and addiction services, exchange our knowledge from both sides, from the HIV area and the addiction area, exchange our knowledge and do mutual trainings, disseminate harm reduction strategies about chemsex users, and modify existing evidence-based therapies for substance-related disorders for the needs of chemsex users. Thank you.
Thank you, Enrique. We are all very well in time. We had planned 20 minutes, but it seems we have almost 25 minutes, am I right? Well, 20 minutes to ask questions to the panel and to engage the delegates yourself or the panel members into discussion and bring us forward. Who wants to ask a question? Please go to the microphones and then state your name and put a question. The lady first at microphone number 1, please.
Yes, good evening everybody. I'm Sandra van den Ende from Sensor, prevention organization in Flanders, and I'm very happy to also meet a colleague therapist in the panel. And my question is directed to you. I was very pleased that you were pointing out the needs of people accessing services, and if I noticed well, you mainly pointed out the need or the absence of knowledge in services in addiction. And I would like to invite you to talk a bit more about how do you feel about the need for people to access services who talk about sex. So sexologists, psychologists, and how their knowledge is. Thank you.
I can say from my clinic and from my colleagues, and what I can overview is that we know little about sexuality, and sexuality has nearly no space in our therapies, and that's a big mistake, I guess. But there are some ideas for training clinicians and psychotherapists in the addiction area to talk about sex and sexual health with their clients. And for myself, I was inspired by a colleague from the Deutsche AIDS-Hilfe that gave me some slides and some training for our young assistant doctors and our psychotherapists in training to improve this. But it's very needful. They always turn red when we talk about sexuality in the trainings.
Thank you. Microphone 4.
Hello, my name is Tariq. I'm from Lebanon, representing the Lebanese Medical Association for Sexual Health. And I don't have a question, I just have a very gentle suggestion. I think here in this room we all agree that with the bigger the marginalization, the more significant the risk, which will put any population at a higher risk. And honestly, today I was surprised that there's a key population which is at higher risk that was not represented in the panel, and it was a surprise for me. I mean, the transgendered at a higher risk because they are discriminated from the community and even, unfortunately, from within, from the LGBT community. And living with HIV will put them at double layered stigmatization. And I think that the panel would have been much more representative if it included someone who's transgendered. Thank you.
Thank you. I acknowledge that it's a problem for this panel, but also for this conference all over. So duly noted. Thank you. Microphone 5.
Hi, this is Leila from WHO Philippines. Thank you for the very good and interesting presentation. My question goes to Enrique, the last presenter. I would just like to elaborate on the statement that we should shift from public health to individual care, because I didn't get it properly.
When we talk about using drugs and sexual health, there's always a perspective from the public health perspective. People are a risk, they are a risk group, and that's not useful for individual therapy to watch a patient just as a member of a risk group. He's a human being with its own history and its own needs, and so it's not helpful to see to take the public health perspective for individual therapy. That's my point of view.
Just so it's a call for patient-centered care.
Yes.
Okay.
Thank you. Microphone 7.
Okay. Thank you, all the speakers. This is a very interesting session. My name is William Rashidi. I'm from Nigeria, and I am interested in knowing from the speaker who spoke on mental health in Amazon. I don't know the country, but I'm interested in knowing the demographics specifically. Did you also have, or did it focus on Black people or people of color? Because in Africa, there's a sort of disjointed programming when it comes to HIV programming, and it's very important that we begin to take that into consideration. Thank you.
Yes, thank you very much for your remark. In our survey, we didn't ask for color of people. Just we were tackling on gay and bisexual men. It's a problem. You're right. So we will have to change it, or we are asking, where are your parents coming from? But we didn't mention the color. You're right, but we should do this. You're absolutely right.
Thank you.
Thank you. Microphone 1.
Thank you, sir. Howard Armstead with the Public Eye newspaper in Lesotho. When I was in Liberia during the Ebola epidemic in 2014, there was a meeting convened by the Liberian Department of Health and the US NIH to discuss all aspects of the ongoing Ebola epidemic that was just peaking. Among the comments by workers on the front line from the Ebola treatment units was that Ebola patients were depressed, they were anxious, they were hostile, and they were confused. I was struck by the similarity of Ebola terminal patients with HIV, AIDS. These are the exact same symptoms that in her review article about selenium in the 2000 Lancet journal that written by Margaret P. Raymond, that selenium helps against depression, anxiety, hostility, and confusion. But by the time that this was raised by those people from the Ebola treatment units, and I had raised selenium several times, I was just so tired of raising selenium and being ignored that I didn't want to raise the fact that selenium could help against all 4 of those issues. Now, when the Liberian Ministry of Health asked me to bring selenium to Liberia, and we put it in the Ebola patients, and within 2 weeks, survival rates increased from 45%, a maximum of 45% to 68%, even though a suboptimal dosage of selenium was used.
Can I shortly interfere? The panel members are asking, what is selenium? Is it a medication?
Yeah, selenium is a nutritional supplement that has medical uses. You can buy it in almost any drugstore.
Okay.
And, once the Ministry of Health saw the effectiveness of selenium in treating Ebola virus disease, they ordered 1 bottle of selenium for every patient that they had, 2,600 bottles or so. And the doctor that put the selenium that I had brought into the Ebola patients was named Time Magazine's Man of the Year. Now, I wonder why HIV/AIDS conferences I've been to 27 international AIDS conferences over the years, not all sponsored by IIS. Why do they never address the issue or have a panel on selenium therapy for HIV?
I get your question. Thank you.
That's a question.
Thank you. However, this is a question in the broader context of HIV treatment and cure and whatever research. I suggest that I can't answer that, and neither of the panel members probably. So I'm sorry, but we'll have to move on to the next question. And I think it's microphone 5. I'd like to.
Thank you very much. My name is Noreen Hooney from REPSI, which is Regional Psychosocial Support Initiative. We work in 13 countries in East and Southern Africa. I'm bringing up this because I noted that in your presentations, there was very little about HIV and AIDS and mental health in the African context. And the reason I'm bringing this, in most of your presentations, you're talking about a psychiatrist, a psychologist who is supporting for mental health wellness. But in our context, we don't have that. And yet in our context, this is where we've also experienced the greatest death, the greatest illness. What could be the suggestion of highlighting, making mental health and HIV really become visible? Because in REPSI, we truly believe that all these intervention outcomes can be improved by psychosocial and mental well-being. Thank you.
Thank you very much. I think it's a really critical point. Both the programs that I was presenting are in Africa, and both use lay counselors, because I think you're absolutely right. There's a dearth of mental health professionals, and Jackie can also talk about that. So we very intentionally were using lay counselors, which a number of interventions are starting to do for all the reasons that you brought up.
Yeah, hi. Thanks for raising that. So I am a psychiatrist. I do work in Africa, but I'm a rare breed. So in a hospital for about 3,000 patients, I'm the only psychiatrist in that hospital. And that hospital is considered one of the best in South Africa. So I certainly do know that we can't base interventions on psychiatrists alone. So my role really in Cape Town is about advocating understanding of all persons that come in contact with any medically ill patient about thinking about mental health, whether that be a nurse or a physician or an occupational therapist or a dietitian. That is certainly what I feel my role is, because I can't see 3,000 patients every day. But in addition to that, I also think that an enormous gain can be made by thinking about every single individual person with something that I call absolute positive regard. If every single healthcare professional, whether they be allied health or medical health, can think of every person in that way, the way in which individuals feel about how they're treated, how they engage with care and diagnosis can significantly be changed. Lucy Kluwer presented some data about how adolescents respond in the Eastern Cape of South Africa, which is a very rural area where I grew up. And the most significant predictors of adolescents accepting care were nurses just being nice to them, and she often says she sets the bar very low. Being nice means just don't shout at me. And having medicines available on the same day as the appointment. That's it. Just doing those two things significantly impacted care. So I don't think that we need necessarily to think about enormously complex interventions in people living with HIV, but we do need to think about empathy and absolute positive regard.
Yeah. Microphone 2.
Thank you. My name is Anastasia. I'm from Russia. I'm a psychologist. I'm glad to be here, and it's very important to talk about mental health in the context of HIV. But I want to make a point that we are talking about mental health of people living with HIV in the time when people who have mental disorders first and HIV just second, they are a key group, a vulnerable group for HIV. And this is a question for all the presenters. Are there any ideas or programs how to deal with the prevention of HIV in this group, in the group of people with mental disorders? And of course, there is a specific, maybe you can talk about it, because of course for people with living with bipolar disorder, for example, or people with Down syndrome, it will be different programs. And thank you. That's my question.
Yes, thank you for the comment and the question. You're exactly right. Of course, I tried to lay out the broad continuum of HIV prevention and care, saying that clearly not only mental disorders, but even just, stress and chronic stress and distress and mental health problems very broadly do contribute to acquisition of HIV. Some obvious points in the HIV context would be integrating screening and offering of treatment, as well as things like empathy, at points of STI testing and treatment, HIV testing and treatment. People who test negative should not be simply sent away, oh, you're HIV negative, and sent home. A lot of us here are talking about PrEP being a point of entry for broader health care as well as mental health care to keep people from becoming infected. So I think whatever point, the vulnerable populations that are at risk for acquiring HIV, I think we should all be thinking about how do we integrate initially screening and an offering of some kind of mental health care treatment, empathy, well-being, enhancement for people to avoid then the people becoming HIV infected. Thank you.
Microphone 5.
Thank you. I was one time an editor together with a lot of drug users of a magazine called Dr. Usegood. And that was because we had the idea that the addiction services were not very relevant to the type of drug use that we were seeing in the population. Recreational drug that went out of hand. And the approach that we envisaged and that we tried to propagate was that you could be helped to be a wise consumer instead of this goal in addiction services, and that is abstinence. Abstinence is an irrelevant goal for many people who are taking drugs in a recreational way, and although it might get out of hand, peer support or other support, even from professionals, might help them to be a wise consumer and not go to that goal of abstinence. Thank you.
Thank you. Somebody wants to comment on that from the panel? Probably Dirk or Enrique, perhaps, or are we fine with the observation?
I don't know if it was a question or recommendation. You're absolutely right. I would support what you said.
Thank you. We have 2 more questions, I think, at microphone 1. So we have about 4 minutes, so please go ahead. Microphone 1.
Thank you very much. Good afternoon, everyone. Good afternoon to the panel, and thank you very much for your excellent presentations. My name is Tammy Yates, and I'm the Executive Director of Realize, which is a national HIV civil society organization based in Canada. However, my Canadian accent is very strange because I'm originally from Trinidad and Tobago, so I'm wearing both hats here. In terms of the work that we do at Realize in bridging the gap between the HIV sector and the mental health sector, we come at it from a slightly different perspective to what was brought to the podium by the presenters, and that is that we also hold the Secretariat as the National Coordinating Committee among civil society organizations in Canada on HIV and aging. and older adults living with HIV. So we're looking at 50 plus, 60, 70, and I dare say even 80 plus, thankfully, with antiretroviral therapy, would have very specific mental health needs and services, and of course, very varying access points. So I want us, and again, it's not a dichotomy between, for example, pediatric care and geriatric care, but we have to have a life cycle approach to mental health and HIV. So I would love for a similar panel to be done in 2020 where we look at a life cycle approach from cradle to chair, and that chair is the rocking chair. Thank you.
Thank you. Beautiful. Thank you. Excellent. Last question, I think, for this session. Microphone 1, please.
I'm David Stanton from USAID, but my comment and question comes from my past life as a clinician in the 80s and 90s. It was going to be a long story, but I'll cut it really short. We have known for at least 30 years that when you offer services to people with mental health problems, the vast majority welcome that. We've also known that the vast majority get better. They feel better. They tell us they get better. But we've known this for 30 years, and yet we're having this session today. And I think one of the issues that I didn't hear, and I'd love to hear the panelists' views, is the role of providers as gatekeepers to mental health services. And what are we doing to address the provider bias and the provider stigma around mental health to this day? Thank you.
Thank you. A very important question, also given the fact that of all health spendings worldwide, less than 1% goes to mental health. And having said that, Robert, would you further like to comment?
Yeah, and other people can comment as well. It's an excellent, excellent point. And you're right. I mean, we've known what we've known for a long time. I think that, well, I think any entry point and paying attention, primary care providers, and depending on, I think wherever they work, they feel overwhelmed and they feel like it's not their position. But there are tools that have been integrated into primary care. There are tools like something called PrimeMD, where you can, there are just very brief screening questions that have been validated to actually capture people for further evaluation. So it can, so that the degree to which we can advocate for general care providers, nurses, whoever interacts with a patient, to at least do screening. Some people are advancing these screening tools by having them self-assessed. I've seen clinics where actually in waiting areas, people are filling out, when they have to fill out questions about demographics, there are some questions integrated in there about how are you feeling? And someone had a slide about how are you feeling? But you can use very standardized screening questions. So I think we can all be creative, and I'll let other people talk about any opportunity to do at least that initial screening, to know that someone has something they may want to talk about. Maybe the primary care can't do a full follow-up, but there could be subsequent follow-up with a team approach.
I agree with all of that. I also think it's not always providers. So I think, for example, with young people, that may not be the first place they're going. So thinking about other systems or communities such as schools or even peers to help people. There's so much stigma around mental health that is actually a huge barrier in itself. There have been a number of trials of mental health programs for early adolescents or later adolescents with HIV, and 40 or 50% of people will come or show up. And so all of those things need to happen.
So I'm a consultation liaison psychiatrist, which means that I'm sort of at the interface between medical care and psychiatric. So I care for all the mental health needs of Kudex Hospital. So yes, the physicians and the surgeons and the infectious disease specialists and the obstetrician gynecologist are the gatekeepers. And their gate is the following: if the patient behaves badly, call Jackie. So that's obviously not good enough. And there is, so I think before the mental health screening can happen, we need to address the significant stigma that our patients face from our medical colleagues. In addition to that, the significant stigma that mental health workers, including me as a psychiatrist, face from my medical and surgical colleagues.
If I may, one last word. Stigma is key to so much, and over 30 years, it's been interesting if you look at what could have countervened stigma. 1998, Joop Lange came up with an idea, treatment as prevention. It was not listened to. Then in 2008, the Swiss position statement about the importance of undetectable viral loads equaling intransmissibility was, received with much criticism. Now it has become almost the mantra of the conference. So let's say that in 30 years, I think that stigma hopefully decreases enormously, and we'll also have less mental health problems, hopefully. Then my last thing is to thank you all, the panel members, and you as an audience, and I hope you have a wonderful evening and the last day of the conference tomorrow. Goodbye.